Hello everybody, I would like to welcome you to our second progress report. My name is Judit, Xenia, Jockers, and my topic is the identification of predictive and prognostic biomarkers in polyposis syndrome. I'm a pediatric resident at Semmelweis University Düsseldorf Street Department and a PhD student. My vision is to enhance chances of survival and quality of life in patients with polyposis syndrome, and my mission is to develop an accurate diagnostic and management protocol by monitoring through the genotype-phenotype association. I have two ongoing topics, and I would like to show the first topic, which is investigating the association between the genotype and phenotype in pediatric patients with polyposis syndromes. Here we would like to develop a systematic review and a meta-analysis. Shortly about the background. Genetic changes are the main cause of cancer, especially in pediatric patients. These genetic changes determine the type of a disease and thereby its characteristics. In other words, its phenotypes. With modern diagnostic methods like new generation sequencing, it is possible to profile hundreds of cancer-associated genes. Due to research, they found out that around 10% of pediatric cancer cases show a germline mutation being part of a cancer predisposition syndrome like the polyposis syndrome. Despite having these tools, there is still a knowledge gap in the association between the genotype and phenotype in pediatric patients with polyposis syndrome. Therefore, the aim of my study is to find the genotype-phenotype association in pediatric patients with polyposis syndrome, thereby determine the course of the disease and make an early diagnosis possible to find the best management and therapy option to improve the quality of life and enhance chances of survival in these patients. My clinical question is, what is the association between the genotype and phenotype in children with polyposis syndrome? Where my population would be children with polyposis syndrome. The exposure is a genotype variance of polyposis, and the outcome is the different phenotypes with the type of disease, clinical features, onset time, course, and manifestation. My hypothesis is that genetic variances of polyposis syndrome can be associated with clinical variabilities. For my systematic search, we used the search key that you can see below, where we had 18,500 articles and in the end 144 eligible full text. Currently, we are done with the data extraction and still in the phase of the data analysis and started with the risk of bias. With the beginning of my work, we divided our outcomes into two groups. One is the genetic background and the other one is the clinical manifestation. In the first step, we analyzed the chromosomes and the genes of the different diseases. And the next step is going to be to find the exact location of the mutations and to find their sequences. The other part is the clinical manifestations, which we also divided into two groups, the intestinal manifestation and the extraintestinal manifestations. The intestinal manifestations contain the polyposis and the GI malignancy. The extraintestinal manifestation different from disease to disease and show different characteristics. In my next slides, I'm going to show you two of the different extraintestinal manifestations, each of a different syndrome. The first plot shows the prevalence of extraintestinal tumors in patients with familial adenomatosis polyposis syndrome having a mutation in the APC gene. We have overall 11 articles divided into three groups. The first group shows the appearance of the typical FAP, where we had 140 patients, and we can see a proportion of 5 patients out of 10 could show an extraintestinal tumor. The second two other groups, which is Gardner syndrome and Turco syndrome, which are a subtype of familial adenomatosis polyposis syndrome, show a higher number in extraintestinal tumors, where we could see that around 8 out of 10 patients show an extraintestinal tumor. The second two groups shows us that it is more typical to see extraintestinal tumors in those. Overall, we had 158 patients, and 6 out of 10 patients would show extraintestinal tumors in this disease having a mutation in the APC gene. We can see a very wide range of heterogeneity, which is due to a low patient number within one article, in each articles. But this outcome is still clinically relevant because we can see that it is not enough to know where, in which gene we have a mutation. There is a big genetic variance that leads to different clinical manifestations. So in conclusion, we can see that a more detailed analysis of the genetic background in these diseases is necessary to see to predict the course of the disease and these syndromes. My second plot is about the prevalence of macrocephaly in patients with P10 hamartomatosis polyposis syndrome, also showing a mutation in the P10 gene. Here we have 3 subgroups as well. The first one is the typical appearance of P10 hamartomatosis polyposis syndrome, and the second is the Banayan-Ryan-Rubalcaba syndrome, and the third one is the Cowden syndrome. The second and the third group are typically to have macrocephaly, especially the Banayan-Ryan-Rubalcaba syndrome, where we can also see that in all of the patients we found macrocephaly. In the typical appearance, macrocephaly is not always present, but still a very high number is there. We can see there a very high heterogeneity again, due to the small number of patients in the articles. And the outcome of 95 patients, over 9 patients out of 10 would show macrocephaly. This is clinically important because it could be seen as the first sign of this disease, while extraintestinal tumors and other symptoms are not there yet. So if we see a patient with macrocephaly around birth, we have to consider also that these patients could have a P10 hamartomatosis polyposis syndrome. In our articles, we had several strengths and limitations. First of all, this is a rare disorder, so we don't have a high patient number, which is a big limitation. But in our articles, we have individual patient data and uniform reporting of the clinical manifestation and detailed information about the clinical manifestations. On the other side, the limitations are that there are different diagnostic procedures, and since we don't have a unique management of these diseases, everybody is treating them differently. And also the description of the genotypes is very different in every article. My second topic is the investigation of the association between the vitamin D levels and malignant transformation of intestinal polyps in pediatric patients with polyposis syndrome, where we would like to develop a systematic review and meta-analysis and a prospective multi-centered study. Shortly about the background. We know that colorectal cancer is the third most common cancer in our population, and 90% of it occurs from colorectal polyps. Given this high prevalence, the question arises if there is a way of prevention and if we could start prevention in childhood. Due to previous researches, we know that vitamin D and can reduce the risk of tumors, and due to its antiproliferative, pro-apoptotic, and immunomodulatory effects. So the question arises if vitamin D could be used as a chemoprevention in gastrointestinal polyps. My clinical question is if the vitamin D level influences the disease course in patients with polyposis syndrome. And again, we would have a population of pediatric patients with polyposis syndrome. The exposure of a low vitamin D level in comparison with a normal vitamin D level, and the first outcome would be the malignant transformation, and the second is the onset, disease course, and chemoprevention. My hypothesis is that a low vitamin D level affects the course disease negatively in patients with polyposis syndrome. To summarize, the aim of my study is to gain a comprehensive understanding of polyposis syndromes, and not only to find the best management and therapy option, but also to find a way to prevent malignant transformation. I would like to finish with one of my favorite quotes. Learning and enjoyment are the secret to a fulfilled life. Learning without enjoyment wears you down, and enjoyment without learning dulls you. Thank you very much for your attention.
Thank you for the presentation and keeping the time. So, exactly. Yes. So, the floor is open for discussion. Any questions before the coffee break? Okay.
Everybody wants to get coffee?
Yeah. I have one question. Because the familial adenomatosis polyposis is associated with several different types of extraintestinal tumors, yes. Will you be able to analyze the data regarding the genotype and the different extraintestinal tumors?
Yes, actually, we like I showed the overall of the extraintestinal tumors, but in our analysis we make a differentiation between the different types of tumors, and also to find the different genetic backgrounds in the sequences for these different tumors. So we hope to have a result in the end. Yes.
Okay, so it's quite exciting. Any other questions?
Thank you for your presentation. I just have one question. I'm not sure if you already investigated that, but do you know what's the difference between the first study and the last study? Because in one of the studies, there were 12 patients. None of them had extraintestinal manifestation or cancer. And in the last study, 6 patients, and all of them had some extraintestinal.
Yes, the difference was this in the last study where we had 6 patients. The study itself was about patients with extraintestinal tumors. So they were focusing within a centrum on patients with extraintestinal tumors in FAP. And the previous studies, they showed all the patients they found in their hospital or in their area with FAP. So, yeah.
Thank you.
Thank you very much.
I have one more question.
Yes.
As a pediatric gastroenterologist, I follow up some patients with polyposis syndrome, and my question is, what is the recommendation? When shall we refer our patients to the oncologist? So, what is the Hungarian practice, maybe?
Well, it depends on their symptoms. I think, like in the current management protocol, it shows that if patients show a high number of polyps with severe gastrointestinal symptoms, they should see an oncologist every 3 months and get an ultrasound of the thyroids and all of the stomach to possibly find tumors. But we know that this is not really sensitive, so it's hard to find these tumors. That's why we suggested that having a exact genetic background, we could predict the course of the disease and therefore find a better management option, not only to send them every 3 months to the oncologist, but to have an exact age when to send them with which tumor to find.